Hi, everyone. Thank you for attending our virtual dental shadowers session. We want to remind you that in order to get your hours, you will have to take a short quiz. And as long as you get 3 out of 5, you will earn your hours. The quiz will be located in our link tree, which is in our Instagram bio. All right, let's get started. We are very fortunate to have Dr. Joshua Austin today. I'm going to hand the mic over to you. Feel free to start whenever you want.
Thank you so much. What an honor it is to be with you guys tonight. And I always start by showing a picture of my dad because my dad was a dentist. And I show him in every lecture that I do for a couple of reasons. I'm proud of him. I'm proud of what he did for dentistry. He taught for he practiced for 25 years in Amarillo, Texas. And then in 1983, sold his practice. And we moved to San Antonio, Texas, where he began teaching at the dental school here in town. And he was the first faculty member at the dental school here in San Antonio who had private practice experience. And so, the vast majority of dental students and future dentists are planning to go into private practice. And really before, in the 70s and 80s and even beyond that, the vast majority of dental school faculty were former military. And so they tended to make things like 4 years of boot camp and then not necessarily teach like private practice methods. And so dentists and dental students had to graduate dental school and then get out and then sort of pick up the ropes of private practice. And so I'm proud that he was able to go and teach young dentists and dental students what it was like to be out, what it was like to be out in private practice and what that world was like. And so I recently found some photos of his office and I love to go through them because they're just like looking through a time machine back at dentistry of a different age. And none of you guys are going to recognize any of this stuff, which makes it even more fun. So this was my dad's dental office. This is the Amarillo Dental Building, a 5-doctor group practice that opened in 1972. A 5-doctor group practice nowadays is not a big deal. We see them everywhere all the time. No big deal. But in 1972, this was a really big deal. And they were the biggest group west of the Mississippi when this office opened. And so I'm proud of my dad for being forward thinking about the practice models of dentistry and realizing that a group practice would be a good way to do dentistry. And so, I think that's a great thing. The building still exists. It's still there. It's no longer dental office is now the Clear Channel Communications television studio for the city of Amarillo, Texas. So interesting that the building is still there, just no longer a dental office. This is view inside the waiting room. And this is, I don't know, when you look at the motif of this interior design, I would use the adjectives of classic, timeless, super modern. This photo could be taken in 1958 at Mies van der Rohe's apartment or in 2019. Obviously, I'm being facetious with that. This photo was definitely taken in 1972. In fact, this photo is so 1972 that you can actually like figure out what week it was taken in. That's how 1972 it is. If you look at the front desk, you will see that there are no computer screens at the front desk, and there's actually no computer screens anywhere in the entire office, which is kind of jarring to see today, where we have multiple screens in every room of our practice now. To see a dental office with no screens anywhere is kind of crazy. Here's a view from the other side of the waiting room, ostensibly in another zip code because this waiting room is so big. I mean, you could play a full court NBA basketball game in this waiting room. And in today's day and age where most of us aren't using our waiting room to at least its full capacity because of COVID, like looking at all this wasted space is just like wild. I know that there were 5 docs, but geez, like maybe run on time so that you don't need as big of a waiting room. How about that? This next photo is my second favorite photo of the entire series. This is my dad's office manager, Georgia. And Georgia was just the epitome of a sassy Southern woman. I mean, she really reminded me of the movie 9 to 5 with Dolly Parton, which is an old classic that none of you have probably ever seen. If you ever watch that movie, she is Dolly Parton from 9 to 5, just sassy Southern sayings like kiss my grits, unironically, stuff like that. And she was just a gem. She had that beehive haircut from 1958 until the day she died in 2004. And if you look behind her on the desk, that's the Dentrix or the EagleSoft or the Open Dental, like whatever computer software system you're used to using. Like that's it. It was just a book with paper and you just used to write it down. I don't know how anybody kept track of anything, but that is what it is. And I love this woman behind Georgia, who I don't know who it is. And My dad was always obsessed with having me busy with stuff. He always wanted me doing something. He didn't like it when I wasn't doing anything. And he used to yell at me all the time. If you've got time to lean, you got time to clean. And that's all I'm saying for this woman is if you got time to lean, you got time to clean. Like, where was my dad on this one? He used to scream it at me nonstop. And like, here this woman is riding the clock, just leaning up against that file cabinet, making sure it doesn't fall over. Where is he screaming her to pick up a dust cloth? Like, that's all I want to know. That's all I want to know. This is the other office manager, Debbie. Say what you will about Georgia being stuck in the 60s. Debbie, with that permed haircut and cut off sleeves, is ready for the 80s. She's ready for Def Leppard to pour some sugar on her as she writhes around on the hood of a Camaro. If you combine Georgia, who's stuck in the 60s, and Debbie, who's ready for the 80s, you combine those two and average them out, you've got the 70s. So we've got our one that's a decade behind, our one that's a decade forward, and you average them out, and you're landing on the appropriate decade between the two of them. This next photo is a room I don't have in my office. I don't have a library. I mean, I guess I do, but the library that I have is all on here. I can look up everything on there. I don't need a book for everything or a journal article for everything. If you look at the back table there is a screen there, but that's not a computer screen. That's actually something called Microfiche. So Microfiche used to be a way that they would archive things. And when you did research, you'd have to use a Microfiche, and they would send out these like little 3x5 index cards that were printed on transparency, and they would make the print really, 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 really small. So they'd fit an entire year of journal articles on this one 3x5 card. And that's how people got their journal articles back in the day. And so you'd have to put it on that thing, and that thing would blow it up so that you could read it and do your research. And I always noticed something new by looking at these photos. And a couple weeks ago, I was looking at these. I noticed for the first time an object on the far side of the conference table there, an ashtray just in the middle of a dental office on the inside. No explanation, just like it's naturally supposed to be there, which makes this next photo a little, make it a little bit more sense. So the architectural plans for the office, which I've looked at, label this next room the smoke and coffee break room, which is apparently exactly what happens in this room. We've got our business assistant here, whoever that is. She's got her pack of Virginia Slims on that table. She's got the ashtray right next to it that's full of just cigarette butts. And I just can't imagine just in the middle of the day, like telling my assistant, like, hey, that was a tough patient. I'm going to go in here and smoke out a Marlboro Red. Like, let me fire off one of these heaters. I just can't imagine. It's like inside in a dental office. This feels like it was 100 years ago by looking at it. I just can't imagine somebody smoking inside of a dental office in today's day and age. But apparently happened a lot back then, because we're now on our second ashtray, and I'm sure there's more hidden around the office in different spots. I love the wallpaper in this room. And there's nothing like putting a really loud wallpaper in a small room and then putting a mirror in it to make it feel like you're in a circus fun house. And then combine that with the chairs, whose pattern on the chair matches the wallpaper. I don't know how you're supposed to find anything. Like, this is like the world's best camouflage room. Just feels like, it feels like you're in a fever dream. This is one of the operatories, and love that chocolate brown furniture and delivery system. Looking great, looking very on brand for 1972. I love the fact that there's a phone in the operatory for reasons why I can't explain. I don't know why you would need a phone in an operatory. Who's on the phone? Who is the phone for? Is it for my dad? Is he talking on the phone, like while he's doing procedures? Is it for the patient? It's right by their head when the chairs reclined. I've spent my entire career trying to get cell phones out of the operatory between both my patient and my dental assistant. Now my dad is just sort of like, hold my beer, and I'm going to put a phone in the operatory and be the first one to do that. Just craziness, absolute craziness. And that furniture does come in red. So when you guys are looking at building out your office, just know that you do have color choices when it comes to this furniture. If this furniture is something you want to add, and this motif is kind of what you're going for, very chic and very retro. I haven't seen the catalog from this furniture, but I would assume that in 1972, it did come in a third color. Avocado green, but we can't put avocado green furniture on red carpet. This place is classy. Come on, we ought to make better interior design choices than that green on red. And this next photo is my favorite photo of the entire series. This is my dad, and I just wish I knew what someone said to him before they took this photo, because the only thing I can think of when I look at this long red hallway is a scene from a movie called The Shining, which you guys may or may not have seen. It's a classic old horror movie where the blood gets off the elevator and we get the red hallway, and we just have this red hallway effect here, which just makes me think of The Shining. I mean, what on earth were they thinking when they made this choice? I mean, I know people did a lot of drugs in the 70s, but I do feel like it takes a pretty specific mescaline high to think that this is the right design choice. Since this office was built in the 70s, there are literally no windows anywhere, which means we can't answer the eternal question. Does the carpet match the drapes? Because, you know, I've always wanted to know. And at least it was shag carpet, which seems totally on brand for the 70s in the paraphernalia that I've seen over the years. A little bit about me. I graduated from University of Texas Health Science Center School of Dentistry in 2006. I worked as an associate for a few years in a couple different practices. Then I opened my startup business in 2009. And then kind of went from there. And so here is my office. My office is in San Antonio, Texas, where I went to dental school. Not too far away, maybe 10 miles or so from the dental school campus that I went to. And I'm in the process of looking at my options for expanding and maybe moving and bringing on a couple other doctors and you know, buying out a couple practices and combining them all together under one roof, wherever that may be. So that's sort of stuff that is on my horizon coming up. I do have a really nice cushy gig with Dental Economics magazine, where I'm a monthly columnist and editorial director. And so Dental Economics is the most read dental magazine in the country. And we put out really great information, everything from clinical information to business information, HR stuff, marketing stuff, everything in between. So I have a column that's called Pearls for Your Practice, which is a product review column. So anytime a company comes out with a new composite or adhesive or cement or scanner or whatever it may be, they send it to me and I get to play with it, and then I get to write about it. And so it's a really sweet gig, and it's a really sweet deal where I always have cool stuff coming my way, and you know, I get to play with the newest, latest, and greatest things. And that has led, having that position has led to me having a career as a speaker to dental continuing education events, speaking to dentists and dental team members at different CE meetings and different continuing education events, which I really enjoy. Several years ago, I did a big meeting of about 8,000 people. I did their main stage general session, which is what this photo is from, called Dentsply Sirona World. And so that was, you know, one of the highlights of that part of my career. But I really enjoy it. I was, like, for instance, last week, I worked Monday, Tuesday, and Wednesday morning, and then caught a plane to Los Angeles on Wednesday afternoon, spoke in Los Angeles on Wednesday night, spoke in San Diego on Thursday, and then flew back Friday morning, and then, you know, worked a little bit Saturday morning, just because you know, that's kind of how the week worked out. But generally speaking, those speaking engagements are typically on like a Thursday or a Friday, and so I'll work my week and then cut my week a little short and go wherever that may take me. Hopefully in a couple of weeks, I'm contracted to go to Cologne, Germany. So we'll see if that actually happens based on all the new COVID stuff. But it's a really great part of my career. It's something I really, really enjoy, and you know, highly recommend it if you enjoy being in front of crowds and having a microphone and you know, trying to teach and make people laugh. It kind of all goes hand in hand in my opinion. And so you know, it's really something that I enjoy greatly. I also have a podcast, which you can find on iTunes, Google Play, Stitcher, Spotify, Podbean, anywhere that has podcasts. If you just search for Working Interferences, you'll find it. We are a dental comedy show. So that just seems like a strange genre, but it is. So we do a lot of advice questions. And so people will send us questions about weird things that happen in their office, and we answer you know, those questions. Specifically trying to be bad. If you've ever heard of a podcast called My Brother and Me, we basically try to do the dental version of that podcast. We also go to the dental subreddit on Reddit and find the weirdest questions we can find, which for some reason all have to do with, like, can someone have oral sex after they have their wisdom teeth removed? Like that's almost a daily question on that subreddit, which is crazy. And so we just make fun of those questions and try to, you know, pick out the little weird esoteric things that happen in a dental office, because for some reason, weird things just happen in a dental office. I can't explain it. It's just a weird place. Weird things happen. And there's a lot of hilarity to be mined from those weird things. It said in my About Me that I survived 2020. And I feel about like Bo Burnham does here about, there were times I felt like this last year. And most dentists probably did, anybody that you talk to, like it was just an incredibly difficult year, still incredibly difficult with COVID running rampant. And I've got, one employee that's, tested positive last week, and, so she's out, and it's just a mess. If you haven't seen Inside by Bo Burnham, which is what this is a reference to on Netflix, like go watch it. It's so amazing. It's supposed to, it's like a comedy special, but it's really not. It's so much deeper and has so much more to it than that. So I just couldn't recommend it more. And I think once you watch it, if you have seen it, you kind of understand that the Bo went through some stuff when he was making it, and just like the rest of us dentists went through some stuff and are still going through some stuff. And so I've been kind of on the vanguard of talking about it, talking about how difficult this time has been, and how hard it's been on all of us, and how hard every day is, and that it's, I started seeing a therapist at some point last year, and it's actually really helped me. And so I've decided to share that message with dentists and dental team members, and talk about the importance of therapy, both for us and our patients as well. I run across a lot of patients that have some pretty specific phobias and whatnot that really need professional intervention other than me. It's something I'm not trained to deal with very well. And so if you're interested in this, you can find this at bit.ly/dental mental health. I don't make any money from anybody signing up and watching this on-demand course. Is there if you need it, and if you want it. It's kind of sort of half stand-up comedy and half continuing education lecture. So if that's anything that you think you might be interested in, just check that out. Let me tell you a bit about my practice. I mainly focus on restorative and cosmetic dentistry. Like I said, I opened in 2009. Currently, it's just me. I'm looking to change that because I am gone a lot. And so it would be nice to have another doctor here to help me out with some of that load. Right now, I have 10 employees, 9 COVID negative employees, 1 COVID positive employee. 4 of those are hygienists, which can sometimes be the bane of my existence when they're bugging me to go get up from what I'm doing and go do a exam for them. But it just is kind of what it is. And then really starting in 2021, really started to move a focus towards Invisalign, which has been a big part of what we do. You guys all recognize this, right? I mean, you guys all have one of these, a smartphone, right? Whether it be an iPhone or an Android. And at least half of you are probably on it right now, flipping TikTok or Instagram stories while you're listening to this. When I think back to 2007 and when I got my first iPhone, I thought I was buying a phone, and I did. Technically, it was a phone. But in 2021, we all understand what this device really is. It's far more than just a phone. In fact, it's barely even a phone. It has become the digital hub of our lives. It's our connection to friends and loved ones and pimple popping videos. The iPhone is great technology, and it's put the world at our fingertips. It's literally anything and everything all of the time. The thing about great technology is that it integrates itself so much into your life that you cannot fathom living life without it, because it makes so many things you do faster, easier, and better. Faster, easier, and better. Aren't these the goals that we all have for our dental practice? So what's our iPhone in dentistry? What allows us to see more, do more, and do it better? Isn't this how our patients want to be treated? When I think about my digital scanner, I bought it as a single system device, as a single output device. It was simply bought to replace impression material in my office. But while it does that very well, whether it be for crowns or for Invisalign or for whatever, just like the iPhone, it does so much more. And by the end of my time with you, I want you to see that a digital impression scanner is far more than just an impression scanner. It's actually a treatment acceptance machine. And for us in our office, that all starts with what I call the Itero-driven new patient experience. And so what that means is that everybody who comes into my practice as a new patient gets scanned by either my hygienist or my assistant with our Itero machine, which is our intraoral scanner, digital impression unit. And then we review that with the patient. The hygienist reviews the things that she's interested in, i.e. how much plaque and tartar and stuff like that is around their teeth and where it is. And then I come in and review the stuff that's important to me, basically their state of their teeth, broken teeth, decayed teeth, wear on their teeth, things like that. And so using this, it has really been able to give us the opportunity to show patients what's happening in their mouth in 3 dimensions, on a touch screen right in front of them, to show them things that they would never, ever see before. And that has really opened up the door to patients trusting us, trusting that we're not trying to sell them something that they don't need, and then saying yes to that treatment. So one of the options, one of the things that we use it for is something called Timelapse. And so what Timelapse does is it takes 2 scans done on at least different days. Although if you did a scan one day apart, you wouldn't notice any difference. But in this situation, these scans are a couple years apart, 18 months or so apart. And so it will then show like a GIF in the upper right-hand corner that you can see there that shows how those gums have receded between those 2 times. And on that stone model part in the middle where the circle is, it puts it in red, because that's, basically an indication to the patient that something is wrong. Red means bad, right? So when you can show a patient this and show them like, hey, look how your gums have dipped down here in this time. Like, this isn't just me telling you, this is me showing you what's happened with actual concrete scientific data surrounding it. And so this has really been a game changer when we talk about recession and when we talk about wear with patients. Many of these different intraoral scanners, the different brands have different features, but a lot of them have something called caries detection. Caries is basically decay, right? So it has decay detection in the scanner. And so the one that I have, Itero, which is owned by Align Technology, or basically owned by Invisalign, that when it sees decay, it lights up white in between the teeth. And so this particular caries detection algorithm is really good at finding decay in between the teeth, which sometimes does not show up on x-rays. And so it's nice to have this as a backup. Plus, it really helps patients understand where their decay is that they can't always understand from a 2-dimensional x-ray that they see on a screen, right? So this is actually kind of like a 3-dimensional x-ray, but better. It's actually infrared imaging of the teeth, and it lights those areas up white. Now, we also use this scanner all the time for our restorative dentistry. And so, we use it in the hygiene room for new patients, but we also use it as it was designed to be used for crowns and bridges and veneers and implants and things like that. And so here's a tooth that comes in. This is Jerry. Jerry came in with a broken cusp on his lower right first molar. This photo is taken off of a mirror, so that's why it looks like it's the left side, but it's actually the right. And you can see some dentists somewhere put a little filling material on it, but it's a pretty weakened tooth. It's got a big crack through it because of the amalgam that's there. And so we prep that tooth down, which basically means that we remove about 1 millimeter from the chewing surface and 1 millimeter around the tooth, so that the crown has something to grab onto, right? We have enough space for the crown. We need about 1 millimeter all the way around of this particular crown material to have enough space and have it be thick enough. And so that's what you're seeing here is a reduced tooth. The white stuff that you see on the skin there, that's called a buildup. And so after we prep the tooth down and then take out all the old silver filling, we want to build the tooth back up to where that preparation should be and where that prepared tooth should be ideally. And so that's what a buildup does. So a buildup kind of adds contour back where we lost it to previous disease. After that's done, you can see a red line around there. So that red line is what we call the margin. And the margin is the most important part of a crown. That's where our tooth and the crown meet. So those have to meet perfectly all the way around. We need those margins to be closed and smooth so that bacteria and plaque and stuff like that can't get underneath them, right? So we have to tell the laboratory that's going to make this crown for us where that margin is on the scan so that they know where to do it. And here's a view from the cheek side that kind of shows you that red line as that red line dips down. And so That red line is marking the margin. And so we prepare the margin when we prepare the crown. We have specific burrs that kind of give us the adequate thickness there. And so we want those margins to be nice and smooth and readable so that we can mark them here and so that a laboratory knows where they are so that they can build the crown down to where they need to so we don't have an open margin down there where stuff can get into. And so this is what the crown looks like when it is done and in. This is a material called zirconia, which is a all ceramic material, meaning there's not metal there. It's just this white colored ceramic that is what we call monolithic, or a single layer of porcelain. And that gets bonded with cement onto the tooth. And here is another view of that from the tongue side, and you can see how well that fits there. And then here's an x-ray of that. You can see that lower tooth in the middle there. This is what we call a bite wing radiograph. And so you can see how smooth those margins are up against the tooth. This is kind of what we're looking for here. Really nice smooth margin there. And that's what digital can do because there's no distortion. There's no, errors with mixing the impression material or tears or distortions or anything like that. And so generally speaking, when you use a digital scanner instead of impression material, things just end up fitting a lot better, which is demonstrated here. The other thing that happens is that because this gets emailed to the laboratory, basically they can start working on this file right away. And so it trims about a week to a week and a half off of the crown fabrication process. And so we typically cement our crowns in 4 days, 4 to 5 days or so after we prep them, which is a far departure from the traditional 2 weeks, which is kind of what it has always been, because that's how long it would take to pour up an impression in stone, manipulate the stone how it needed to be manipulated, then design the crown and do all the different steps of the crown. Whereas this, we skip all that stone stuff, and then everything is being designed digitally by the lab. And then they fabricate the crown digitally with a milling machine. And so you can see here, this crown was submitted on June 19th, and it was shipped on June 22nd. It would have shipped earlier, it would have shipped the next day, would have shipped June 20th, but June 20th was a Saturday. So we prepped it on a Friday. It shipped from the lab on Monday. And it got to my office on Tuesday, and we seated it on Wednesday. So we prepped it on Friday, seated it on Wednesday. And so when you seat crowns that quickly, it just changes the ball game as far as how well those crowns fit and how easy that process is of putting the crown in, because nothing's had time to move or shift or change in those 3 to 4 or 5 days as it would have had over 2 weeks. So another way that digital just completely changes our game. And so digital can work just as well for multi-teeth as it does for that single tooth, including front teeth. And so this is Barbara, and Barbara comes in and she doesn't like the overlap or the color of her front teeth. And so we get a closer look, and I don't like it either. And so we talked about a lot of things with Barbara. We talked about orthodontics and then maybe trying to bleach those teeth. But when you see teeth, especially front teeth that are that dark, they typically have a really hard time bleaching. And even if you do root canals and bleach them internally, it's still a fight. And so we decided to do porcelain veneers. And so we took a digital scan of Barbara. That goes to the laboratory, where the laboratory then does what we call a diagnostic wax up, where basically they make her teeth really pretty on a model using wax. And that kind of becomes our guide as far as what we're going to go by. We're going to use that to make our temporaries and use that to figure out how much tooth I need to reduce to give the laboratory space to make the veneers, all of that stuff. So then the next step is Barb to come in and get those teeth prepared. And so these are veneer preparations on those front 8 teeth. Those 2 front teeth are darker than the others, so they needed a little bit more tooth prepared off of them. And you can tell right at the gum line there, that's what we call the margin. And those teeth are a little bit heavier prepared at the margin than the other teeth because they are darker, which means that we have to give the space, a little bit more space to the laboratory to block out that darkness. And so here's our preparations. There's our scan after the scan is done with our margins marked for the laboratory so they know where we're going. These are our provisional veneers, or our temporary veneers. The patient's going to wear these temporary veneers for the next couple of weeks while the lab makes our veneers. Single tooth crowns you can get away with 3, 4, 5 days, but you really need to give your lab technician time to fabricate like 8 pretty veneers. So this is still one where you have like a 2-week waiting period. So she'll wear these provisionals for 2 weeks or so. You can see her gums are pretty irritated because this is the day that we prepared them. So they're always going to be irritated like that. But here's the day we delivered them. And you can see that white pretty ceramics there. She still has a little bit of crowding on the lower that maybe we'll do something about at some point. And certainly, it would behoove her to do some whitening down there to get them to match a little bit. But you want to give them what they want, which is a nice bright smile. And with her smile, she really doesn't show any of those lower teeth. So we weren't going to let those lower teeth drive our coloration here because, we don't see any of those. So we really went with the color that she wanted, which was a pretty nice white bleach shade, although not the brightest with her darker complexion. Something that's not so bleach white actually looks a little bit better. And then you can see kind of the difference between there and there. She's obviously thrilled with that. We're thrilled with that. And so, that's pretty easy, start to finish process when we use digital with not a single drop of impression material done the entire time. So that works great. We also 3D print a bunch of stuff in my office. And so I 3D print models. We actually don't take any impressions at all in our office. The one time where we may take some impressions is for like dentures, but that's pretty much it. The digital scanners aren't super great at scanning people without any teeth. So if it's somebody who's a edentulous, it doesn't do great for that. But for everything else, if we need a model, instead of taking an alginate impression, which you've all probably had experience with, we simply scan it and then I 3D print it. And that's a much faster, easier type of deal. And that all came down to basically, I hated having impressions done when I was a kid and growing up and going into orthodontics. And so I wanted to eliminate that from my practice as quickly as I could. And so that's scanning and printing kind of went in and did that. We also 3D print our night guards in our office, and we can also 3D print surgical guides for implants. We can 3D print provisionals or temporaries we wouldn't do that for like a single crown. It doesn't make any sense for that. But for multiple crowns, like a big, we're doing a bunch of teeth, printing those would be could have some benefit. And so I suspect we'll be seeing more of that. By the time you guys get to dental school and get out of dental school, I'd expect 3D printing to be even more ubiquitous than it is now. I mean, I think probably maybe 3% of dentists have a 3D printer now. My hunch is it'd be closer to 10% as you guys get out of school. And then I think there's a day in the next 15 years where we all have a 3D printer at some point in our office. It does some stuff for us. It's just a matter of what, and really the technology for 3D printing is all kind of the same. That doesn't have to change very much. What really needs to change is just the 3D printed materials, the resins that we have. We need to see some more ability to print those a little bit thinner and then to use those, get them FDA approved to be used in the mouth for different situations. So 3D printing, something really that I'm doing at least every day in my office, at least once, sometimes more than once a day. Something is 3D printing on my printer. This case right here is a case that really kind of made me realize the importance of scanning patients at their new patient visit. This is Katie. And when Katie came in, Katie basically said that she wasn't really interested in a lot of dentistry. She was really just there to get her free cleaning from her insurance, which is one of those things that when we hear it a lot as dentists. Kind of makes us tune out a little bit, makes us not exactly want to go in and try to get them to do a bunch of treatment, because it's obvious it's kind of not what they want, right? So, whenever I hear that, I'm kind of like, all right, whatever, sure. We'll give you your cleaning. I mean, you paid for it with your insurance, you should get it. So we'll give you that. And so we still do the scan. And so I did the scan. And as I looked at Katie's teeth, I started noticing that her front teeth looked pretty thin. And that enamel looked really thin, and the teeth looked a little triangular, and the edges of her front teeth weren't even. And so this is all just stuff I noticed when I was talking to her. And as I looked on the scan, I saw more of it. Then when I looked from this direction, I could really see more of it. And if you look on the tongue side of those upper front teeth, you can see that basically all of her enamel up there has been eroded away. And this is a really slam dunk. Whenever you see this, we basically know that this patient has had or has had in the past, either does have or has had bulimia. That's just a very specific type of etching and erosion that happens on the tongue side of upper front teeth when we have somebody who's a bulimic. And so, now I got to have a tough conversation with Katie, and she admits that, yeah, she was a bulimic when she was younger. She's now in her mid to late 30s. And, that this is something that happened to her in her late teens, early 20s, that she went through therapy for and has not had, I guess, has not had a purging event in many, many years. And so, but as soon as I kind of showed her this, she was very interested. And she did not know the extent of the damage that she had up there. And in fact, she said something to me that made me laugh a little bit. She said, I've never seen the back of my front teeth before. I'm like, yeah, of course you haven't. No one can see the back of their front teeth. But then that also made me realize, like, no one can see the back of their front teeth. Like, we should show them that, and we can show them that with this scan. And this motivates people to want to do things in these situations. And so here it is in monochrome. So with the monochrome view, you can really see just how thin those teeth are, and how much of that lingual enamel has been worn away. The crazy thing is that she wore away all the enamel of her upper front teeth on the tongue side. But when she bites down, she still bites down on that. So you would think if that was eroded away, I'd still have space there to put some composite back to build her back, but that's not what happens. And what happens is that teeth move as they erode or wear down, so that they stay touching, so that they stay in contact. And so this makes a really tough situation for us, where all of the space that we should have to give her back, at least resin instead of enamel, is gone. Because if we were to put composite on these teeth where composite should be, when she bites down, she's only going to touch on her front teeth. Her front teeth or her back teeth aren't going to touch, which is a problem. So, this means that now we have to do some more exotic stuff than simply just replacing the enamel, because the teeth have moved. So the next thing I look at is her gum lines of her upper front teeth. And almost always when you see a situation like this, where you have worn down teeth or eroded teeth, you'll see the gum lines fluctuate, and hers fluctuate a little bit. Her lateral incisors are a little bit lower, but that's a pretty normal thing. And we're used to seeing lateral incisors that sit 0.5 millimeter to 1 millimeter below the gum line of the canine and the central incisor. But her canines and her centrals are almost dead on. So she's had more movement from her lower teeth than her upper teeth, which is good, because this gives me some ability to do some things with her without having to move her gum tissue out of the way, which is great. And then when I look at her lower teeth, she has some recession on her lower teeth, but her lower teeth have never really been restored. She has 2 small old sealants on her lower second molars, but she's just got a ton of enamel around. And so now I'm trying to come up with some options for her treatment. And now she's really interested in treatment, because she saw how much of that lingual enamel was eroded away. So when we have worn front teeth or eroded front teeth, there's really only 3 ways that we have to treat it. One way is we can move the teeth back to where they were orthodontically, which will open up the space that we used to have. And so then we can do composite or porcelain or whatever we want, because now we have space in between the teeth. So I talked to Katie about the idea of maybe doing some Invisalign, and she says, no, I want it fixed sooner, which I laughed at, because I was like, Katie, 5 minutes ago, you didn't even know you had a problem, and now you're telling me you want it fixed right away? And she was just like, yeah, that's what I'm telling you. Like, all right, cool. At least you're honest about it. Then the second thing that we could possibly do when we have a worn or eroded patient is functional crown lengthening surgery. And so we would typically do this when we have that gum line being off between all the teeth. And if we had the gum line way down, we could do functional crown lengthening surgery, which would then move the gum line back up to where it's even with the other ones, and then give us enough tooth structure so that we could get a nice crown on, or a veneer, have enough length of tooth, what we call retention and resistance forms, to be able to do that. But since Katie's gum lines are all pretty on, if we do crown lengthening surgery on her, we're going to make her upper or her front teeth gum line higher than her back teeth gum line. And then we'd have a step down from front to back, which is just as unaesthetic as having a step down from back to front, which is what she would have if she had more of that super eruption that we talked about, that she doesn't really have. So that's not really an option for her. I don't want to do crown lengthening, because that's going to make her worse. So the third thing that we can do is what we call opening the vertical dimension of occlusion. And let me show you what I mean by that. So I took some flowable composite, and I just put these little knobs of composite on Katie's back lower teeth, and I cured them, and then I scanned her again. And so you can see on the left side, those are her lower teeth. if you look at those back teeth on each side, you'll see those kind of that ridge on the right side and those bumps on the left side. So I added stuff on her lower teeth, and then I had her bite down. And so imagine putting something on your back teeth and then biting down. Well, what happens? Well, then those are the only two teeth that touch, and we have space between all the rest of her teeth. So I showed this to Katie, and the light went off inside of her head. And she's like, oh, I get it. You want to add stuff to my back teeth so that you have space and you have the room to make my front teeth nice and pretty. It's like, yeah, exactly. That's what I mean by opening the vertical dimension of occlusion. Vertical means this way, right? And so we all have a vertical dimension of occlusion or our bite. So if you bite down, the space between the tip of your nose and the tip of your chin is called your vertical dimension of occlusion. As you wear your teeth down, that gets less and less and less. And if you imagine a grandma who has no dentures in, when she closes down, how close her nose and chin are, that's what we call a diminished vertical dimension of occlusion. So we alter that all the time, especially like in dentures and partials. We change the vertical dimension and we build people back that vertical dimension of their face. So you have that grandma who doesn't have dentures in, and her chin and her nose are real close to each other. When we make her dentures, it's kind of what we're looking at to gauge how long the teeth should be, is by determining kind of where in her face is her, should her vertical dimension be, what length should her teeth take up of that. And so in situations like this, where we have worn down teeth, we can actually alter that by adding to the back teeth so that we have space to restore the front teeth. And so now you can see how much space we have there in between her front teeth. What all used to overlap there doesn't overlap anymore. So now we have a ton of space. So here is where we started. And then basically we do, to know where we're going to go on this, like we can't just start throwing stuff in our mouth. We have to kind of have an idea of where we go. And so we start with models, and in her case, 3D printed models. And we work with the laboratory to do it on the models in wax first. And so a laboratory technician will basically make the front teeth really nice and pretty. And then on the models, on what we call an articulator, on the models, the models will bite together, and it will show the laboratory technician, after they've waxed up the front teeth to where we want them to be, how much space is in between the back teeth. So then we just add wax to the back teeth, as you can see here, to make them look anatomic and natural until we have even bite all the way around front teeth to back teeth. So that's called a wax up. This is going to be our guide to where we're going to take Katie. So I 3D scan that wax up and then 3D print it so that nothing can happen to it. It's not damaged. Then I make a suck down tray on that wax up, on that model of the wax up. And we're going to use that suck down tray as basically like tracing paper or a guide to build up her back teeth so that we can do her front teeth. So here we are before we start on the back teeth, and you can see the overlap there of the front teeth and how the lower front teeth bite into the tongue side of those upper front teeth. And so now we're going to add composite tooth by tooth on her lower back teeth. Until we're done. We go tooth by tooth using that tray and heated composite, bonding that in. Here's one side, here's the other side. And then when we're done, when she bites down, you can see how much space we have now. You can see how those teeth don't overlap anymore. And the way you can tell is that you can see the darkness and the thinness around the upper front teeth. Because what was keeping us from having that black there before was her lower front teeth when they bit down, right? So now instead of being like this, we're like this. And so now I have some space to do something with these. So we're going to prep those for crowns. So here we go. We have K9 to K9, or 6 through 11 prepped for crowns. Here are her provisional crowns, her temporaries that she's going to wear while the lab makes the crowns. These are all based on the wax up as well. So these are going to be much more anatomic and fully formed. There she is the day we prepped in her temporary crowns. And really, I just take this photo. She's super numb, so her upper lip doesn't work right. Her upper lip is also really super dry from us rubbing our gloves on them all day. And so this photo, really, we take this photo for is just to show that the edges of those upper front teeth really are contoured by that lower lip. And so I know that those teeth are in the right spot. And we have the right length on those teeth by looking at that, right? They're really contoured nicely by that lower lip. So that's one of the things we go by when we try to figure out where front teeth should be, is where the lips are, is specifically the lower lip. Here are her final crowns in after a couple weeks. And those look really nice. And then here's a final picture of Katie, and Katie's thrilled when we do this. I'm thrilled, and I take these photos. And that night I go home and I load these photos onto my laptop to take a look at them. And I think to myself, damn, I forgot that we extracted all of Katie's back teeth, because it doesn't look like she has any back teeth here, does it? Actually, she does have back teeth. We just can't see them anymore because they're way tilted to the tongue side, and they're darker. And so we made her front teeth bigger and brighter and more prominent. And so that takes all the attention and all the light away, so that it looks like she doesn't have anything on her back teeth anymore. So I had to call Katie back and tell her, like, hey, Katie, I know you're super stoked right now, and so am I, but we're not done yet. We need to do some veneers on your first premolars to get them out where they need to be, because I can't see your back teeth in your smile photo, and I don't want to make it look like you're missing your back teeth. And she said, I've kind of noticed that over the last couple of days. I agree. I'd like to do that too. So here she is with no preparation veneers on her upper first premolars. And now you can see the difference there and how much fuller her smile is from the first shot to the second shot of her smile. And we're much happier with that, because it fits her face much better. It fits her, what we call buccal corridor, much better, to not have all that black back there. But none of that happens if we don't get a scan of Katie at her new patient visit and show it to her, and she becomes aware of what's happening with the tongue side of those upper front teeth. And so that's where it all starts for us, is we get patients to say yes to treatment by scanning them with our digital impression scanner at their new patient visit, and taking them on a 360-degree 3D tour of their mouth on that scanner, so that they can see exactly what's happening to them. An informed patient is a patient that trusts you and that will say yes to treatment. You can't get a yes to treatment unless your patient is informed, understands, and trusts you. Those are the three things that you got to have to get a patient to say yes to treatment. So you could take a dental office like this, which is the operatory where my father practiced, with red carpet and a red chair and a phone by the patient's head. And this is obviously the least modern office of all time. But if you put a digital impression scanner in the corner, it makes it a modern dental practice. It's all you need to become a modern digital dental practice. You don't have to redo everything. You don't need any of that. You simply need a machine like this and using it in the right ways to become a modern digital dental practice. You guys can reach me anytime, jaustindds@me.com, or anywhere on social media at Joshua Austin DDS. And I say anywhere on social media, but I'm not on Facebook because I'm not 60. And I'm not on TikTok or Snapchat because I'm 42. And any 42-year-old man who's on Snapchat or TikTok just has nefarious reasons for being on there. They're either trying to track down their kids, or they have weird, nefarious reasons. So you won't find me on Snapchat or TikTok. Basically, that means Instagram. Find me on Instagram at Joshua Austin DDS. That's the one social media platform that it is okay for a 42-year-old man to be on. So that's where I'm at. Do we have any questions as we wrap up here?
Yes, actually, we have a few questions from the
Great.
Google Live chat. So a viewer has asked, does porcelain in the posterior restoration cause wear to the opposing teeth?
It can, especially some of our older porcelains did. The porcelain is what we call feldspathic porcelain that we used like on porcelain fused metal crowns, was pretty rough on opposing dentition. The newer ceramics like zirconia and emax, especially when they're polished well, cause very little wear to opposing tooth structure. In fact, polished zirconia wears opposing enamel less than enamel does. And so I'm not going to say we've solved that problem because we still have some situations where we need to monitor that, and it becomes an issue if it's not polished. If somebody is a bruxer where they grind their teeth together, there's still some things that can lead to wear, but those old feldspathic, either veneers or porcelain fused metal crowns, just did a number destroying the opposing dentition. And so it's a problem that I don't want to say is a thing of the past, because we still have patients that have those type of restorations and we still see that fairly frequently. But we know that we're not doing that nearly as much as we used to.
Okay, so another viewer has asked, how do you balance life with work?
Not very well for me. I don't have kids, And so, I tend to end up working a lot more than I probably should. And so I'm not a great person to ask about that. I do, have therapy every other week with the psychotherapist, and that's helped me a lot. It's hard to draw boundaries, especially when you're a business owner, because you're not a business owner for 8 hours a day. You're a business owner for 24 hours a day. And so those are hard things to sort of separate and have boundaries on, especially when you own the practice. And so it's a little bit easier to do that if you don't own the practice, but there's some disadvantages to that too. Not everybody probably should own a practice. That's okay. But also knowing that, hey, like being a business owner doesn't like turn off at 5 o'clock. And so, there's times that you have to do things as a business owner outside of hours and whatnot that somebody who's just an employee wouldn't have to do. And so, it's something that we all probably can work on as dentists. But I also see the side of it as like, I'm fortunate to have enough patients and have enough business and be busy enough where I can overwork. There are a lot of people that would love to have that opportunity to overwork. And just don't have the patient load to be able to do it. So, it's glass half full, glass half empty. But it is something that I'm not great at those boundaries, and I need to get better at. And so, check back with me in a couple of years, and I'll tell you. That's a super important thing. But also understanding that if you do want to own a business and you do want to own your practice, which is why a lot of people go into dentistry. That there is, some sacrifice for that. And so you have to be comfortable and willing to make that sacrifice, but also it shouldn't eat up 18 hours of your day. You know what I mean? Like it should, that you should have some ability to have some time for yourself.
Yeah, of course. So another question that has been asked is, do you mind elaborating on how dentists make wax rims for dentures? Because I know it does involve the vertical dimension of occlusion, but
Exactly.
I'm kind of lost on how.
Yeah, so that's exactly right. So wax rims are basically how we determine what the vertical dimension of occlusion should be. So when we're making dentures, we don't, if you're doing a filling, you've got all the other teeth around it to figure out like where the filling needs to be, right? You've got all the teeth, you've got the bite on all the rest of the teeth, like all that stuff guides where your filling goes. But when you're doing dentures, you have nothing to really guide us by except the face, right? And so the wax rims of a denture help us figure out where in the face the teeth need to go. And so it's the second or third step after we take an impression, after we take our master impression. That master impression is then turned into a master model. And then on that model, we make our wax rims. And so a wax or a base plate with our wax rims. A base plate is really just like, imagine a denture that had no teeth on it at all. Just the pink part of a denture. That's what a base plate is. So that's the part that kind of fits up against the tissue and kind of goes up underneath the cheek and down by the tongue and on the roof of the mouth and all that. And then the wax rim is basically just a horseshoe of wax that goes around that kind of right, on top of the arches where the teeth used to be. And then we shape that wax to where the teeth should be. And then that wax rim then guides the laboratory technician on where to put the teeth. So the first thing we do on a wax rim is we put the upper one in and we mark the midline between the midline of the face. And that's where they're going to put the two front teeth right there at that midline, right? And then the next thing we want to do is make sure that the wax rim isn't pushing the lip too far out. So if you think of somebody who has buck teeth and their lip comes out like that, we don't want that. We also don't want their lip to cave in either. So we want to give the lip support. So we adjust the wax rim to where we have good lip support. And then the last thing we do is we adjust the bite. So that's the point where we put the upper and lower wax rims in and we have the patient bite down and we look at their face and determine, like, does it look like there's too much in their mouth? And if so, we reduce a little bit. Or does it look like there's not enough in their mouth and their nose and their chin are too close? So then we add a little bit. And so we just get the wax rims to where they look like they're nice, natural, and comfortable. And there's kind of some landmarks we look at to make sure they're not stretched or collapsed in. And that's when we figure out the vertical dimension of occlusion. Then once we have that done, we just take a record of bite between the two. And then after that, we're pretty much done. And then the laboratory technician will use those rims to put the teeth in based on all those boundaries. They know, where the front surface of the tooth should go right up where the front surface of the rim used to be. They know that the edge of the upper front tooth should be right up against that line that we drew at the midline. And, that facial surface, where the rim was. And so they basically just start there and add tooth by tooth and using the rim as their guide to where things should be. So that's exactly right. We use those rims to determine the vertical dimension, but also where the midline is and where the teeth should go in the face, all that sort of stuff.
Okay, thank you so much. The next question is, does having to buy all the new digital machines make having a dental clinic less desirable?
I mean, that's like, there's no business you can go into where you don't have to like invest in technology, right? There's simply not a one. So like, even if you are an accountant, like at some point you're gonna have to buy new computers and update your Windows and get new document scanners and shredders and all that. So it's like upgrading technology is part of doing business, right? Like unless you want to go, shoe horses or something like that, be a blacksmith with an anvil and a hammer. Like there just isn't anything where you don't have to incorporate technology. So I don't look at it that way. Is there cost associated with it? Yeah, absolutely. Like buying a new scanner costs money, $40,000 to $50,000. But there's like, you use your cash flow from the practice in addition to, tax strategies and whatnot to help you with those sorts of things to try to offset some of those expenses. And at the end of the day, like technology is fine. I have no problem investing in technology if it becomes a profit center for me and if it has a return on investment. And anything you buy needs to have a return on investment. And so for the scanner, the return on investment is getting people to say yes to treatment plans that they wouldn't have said yes to otherwise, right? Because they see and they understand what's happening. And so that's a hard thing to measure, like, hey, would you have said yes to this filling if you didn't have the scan link? You can't really ask a patient that because they're not going to really be able to tell you. But what you can look at is like, all right, here's my production before we started doing that. Here's my production after we started doing that. And is there a difference between the two? And try to isolate out as many of those variables as you can. And for us, it was a 26% increase in production from starting to scan people in their new patient exam versus not. And so we didn't really do anything different during that time. The only thing was scanning them. And so that's kind of how you boil it down. So no, I don't mind investing in technology. It doesn't make it less desirable to me, as long as you get a return on investment. It sucks to buy something and then not get a return on investment and have it end up being a dud. And that's going to happen to everybody. It's going to happen to everybody at some point. But I think the biggest thing is just, doing your research on it, making sure you have strategies with your accountant to make it work, and then making sure you hit your ROI on it. Make sure you hit your return on investment.
Okay, thank you so much for taking the time to talk to us about your profession. It's truly appreciated, and I know that I learned a lot from your presentation. And to our viewers, remember that we will have a quiz that will stay up for 24 hours. You can find the link in our Instagram bio. And once again, I just want to thank you for talking to us today, and to everyone else, have a great day.
Thank you so much. You guys are great.